Thank you very much for your purchase of a PACE educational video. The program that you're about to see is a live seminar entitled Diagnosis and Treatment of the Major Psychiatric Disorders. If you have any feedback regarding how PACE can modify its programs to be of more value to you, please let us know. Additionally, you will find it helpful if you will follow this program using a copy of DSM-4-TR, as I will be referring to that from time to time. Thank you very much. Welcome to PACE Seminar's presentation of Diagnosis and Treatment of the Major Psychiatric Disorders. I certainly hope that today's presentation will be useful, educational, if nothing else, downright entertaining. To introduce myself a little bit so that you all know who I am and what I'm about, my name is Tom Rochat. I'm a psychologist in private practice here in Wichita, Kansas. I originally got my PhD in 1989, University of Missouri, Kansas City. Ended up with a bachelor's, master's, and a PhD from the same university. I found the enrollment process to be fascinating, so I just kept doing it. Decided that I was very regionally bound, so I ran away from home, ran to Philadelphia, PA to do my internship. Interned at a VA medical center in Philly, developed an interest in head injury neuropsychology, and then did a residency in neuropsych at Bryn Mawr Rehab Hospital in Philadelphia. Stayed on staff there for several years, came back to the Midwest in the early 90s. Landed in Wichita, went to work for VA Medical Center. Was at VA for about 8 years, burned out, and decided to try private practice. Found out that a head injury neuropsychologist in private practice in Wichita, Kansas qualifies for food stamps quickly. Okay? So there was a need for me to branch out and do other types of evals. So I started doing dementia evals, sort of like a head injury. That led families into saying, nice job, you've labeled mom, you've put her on a locked unit, so why don't you work with her so that she stops hitting the nurses and work with us on this horrible guilt that we're feeling. So my practice today is primarily with older adults, working with them in rehab hospitals, nursing homes, a good number in the community, reminding them that they're still alive, they still need to be setting goals, and trying to get other people to stop violating their rights. I think the way we violate the rights of older adults in this society is just pretty hideous, okay? I also teach at Friends University. I teach ABPSYC in the fall, I teach theories of personality in the spring, and I started PACE about 6 years ago. I'm now doing seminars in 28 states, traveling 3 weeks out of the month. One hotel room very much starts to look like another. When I do get back home, what I realize is that in my hotel room at home, it's far too spread out. There's no elevator, there's no luggage rack, there's no ice machine, and I've come to expect those things in my day-to-day life. I do have 2 cats. One's mine, the other one's a wild cat that I've had for about a year, and I bring in one of my students to watch the cats when I'm out of town. PACE is now APA approved, we're NASW approved, we're NBCC approved, BSRB even likes us. With all the approvals, we do have some requirements. When you come back from lunch, there'll be an afternoon sign-in sheet, so make sure you sign in again after lunch. And then if you're staying for ethics, there'll be another sign-in sheet for ethics. So sign in there too. Secondly, if you will take the bottom 3 pages of your handout packet and just pull those off at this point, it will stop you from taking notes on those because those 3 pages come back to me later. The bottom page is a needs assessment. If you would fill that out, indicating to us the types of future seminars you would be interested in attending, that would help our planning process. The 2 pages in front of that are a course evaluation. So after you've seen my dog and pony show today, if you can think of ways that I could have been more responsive to your educational needs, please let me know and give me some feedback, okay? By the way, I forgot to mention this morning, PACE is now also offering home study programs. So if you need additional hours or you feel like I'm waiting too long in between seminars, you're going through withdrawal and you need to see me more often, we have home study programs available. To tell you a little bit about the programs that are available, they all carry 6 hours credit except for the ethics tape, which is a 3 or 4 hour tape. The first one I did is called Adult Psychiatric Diagnosis. I've talked about pros and cons of psychiatric diagnosis, what gets coded on each axis, and then I talk about all of the DSM-4-TR disorders except somatization disorder and eating disorder. This tape has probably about an hour's worth of content, which is identical to what you're seeing today. What you're seeing today in this seminar has more treatment implications in it than this does. Another program that's available is a 6-hour tape on understanding the DSM-4 personality disorders, reference to DSM-4 and also to TR. And then there's a tape that'll be available sometime next week called Diagnosis and Treatment of Older Adults. Okay? So all of these are 6 hours credit. If we can be helpful with the home study stuff, let me know and I'll be glad to be helpful. We also have a video share program available, so once you've bought the home study course and you've gotten your CE certs, you can pass the course off to a friend, a colleague, a spouse. They send in a $30 fee to pay, so we send in their own post-test, their own syllabus, and they get their own CEs. So if you work in a large agency or if you have a lot of friends in this business, this becomes very low-cost CEs at some point at 30 bucks a whack. They use your video, they send in the money to us, we send them their own post-test, their own syllabus. Thanks for asking. I would have forgotten that. Let me get just a rough idea of who I have here. How many psychologists in the group? Oh, very good. Thank you all very much. Be a good review. Pillows will be provided this afternoon. Okay. How many social workers? Ooh, lots of social workers. LPCs? Very good. MFTs? Oh, very good. Thank you guys. How many of you guys staying for ethics? Okay, good, because I talked some about AAMFT code. Who did I miss? Okay, very good. Thank you all for being here. Before we get started with going over some anxiety, depression, and did you see the new disorder, physiosis? I knew that a lot of people would show up to know what physiosis is. 3 people proofread these brochures before they ever go out. And the brochure goes out, and I pick it up one day and look at it and thought, physiosis, how did all 3 of us miss that? It's psychosis misspelled. Before we launch into talking about those, I think it's a good reminder to keep in mind that as we talk about these various disorders, you're going to see yourself a lot. But there are some differences. There's some differences between us and those that we treat. And the differences are the 3 rules that we have to look at every single time before we make a diagnosis. We always have to consider, is this disorder due to the direct effects of a substance? And if it is, we don't make the diagnosis. Your patient does cocaine 20 minutes before coming into your office. You are not seeing a manic episode. This is not an anxiety disorder, okay? Number 2, the disorder is not due to the direct effects of a general medical condition. If you have any doubt in your mind that what you're looking at could be medically related, refer it back to the physician and get it worked up, okay? Patients that come to you with anxiety disorders and they tell you that there was a time that they were told that they had some heart valve problems. And you say, well, tell me more about that. And they say, oh, I had something funky going on with my mitral valve. Oh, get them referred back to their cardiologist before you throw treatment at anxiety. Mitral valve disease, very frequently, mitral valve prolapse will mimic anxiety. If you're dealing with any of the endocrine disorders, thyroid problems, diabetes, make sure they're medically stable before making the psychiatric diagnosis. And the third exclusion we have to consider each time is that the disorder has to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. That's why most of us can get by with being in DSM and not being diagnosed. We're bright enough to keep these disorders controlled so that they don't cause impairment, okay? Because the minute we cross that line and it starts causing impairment, we're now diagnosable, okay? So do consider those 3 things each time. First of all, let's take a look at the anxiety disorders. I'm sorry, the depressive disorders. Many of our patients would like to believe that normal mood goes like this, but it really does not. We all have normal ups and normal downs. A couple of weeks ago, I had a certifiable D- day. They just happen, okay? So we all have normal mood swings. But there are some disorders in the DSM that we can conceptualize using this very rough graph. For example, major depressive disorder. Patients go down to a depressed place and they tend to stay here for a while, then eventually come back up to normal, stay there for a while, and then go back down again. Do keep in mind that as your depressed patients start getting better, they start returning to normal, suicide risk becomes very high. And the reason for that is that when they're down here, they think about suicide, they wish they were dead. They develop wonderful suicide plans, but they don't have the energy to carry the plan out. So once they start improving, they've read the book, they've led the life. They know they go back to normal and then they re-tank again. So as they start getting re-energized, sometimes the energy returns, and what they do with that energy is to suicide. So there's always a sense of relief when our depressed patients start getting better. But do keep in mind that it's they start getting better that we really do have to be concerned about suicide. Okay? There is a movie out that I require my ABPSYC students to watch because it tortures them to watch it. But it's a wonderful movie about, it's not a wonderful movie, it's a horrible movie. It's a very good depiction of suicide and how suicide happens and the reason suicide happens. The movie is called Night Mother. Sissy Spacek and Bancroft. The movie. How many of you have seen it? Yeah. Mike, you never saw it? Missed that night, huh? In this movie, it's a very horrible little movie. In the movie, Sissy Spacek comes home, looks at her mother, and says, "Mama, tonight we're going to sit around and talk, and I'm going to organize your life, and I'm going to do your nails, and I'm going to answer whatever questions you have for me. And I'll be asking you questions too, and I want you to tell me honest answers. And then, Mama, after we've had a wonderful night together, you're going to go to bed, and I'm going to kill myself." And this movie is a portrayal of their last night together. It shows Anne Bancroft trying everything she knows to try to talk Sissy Spacek out of this, and it's not going to happen. Sissy Spacek has led a life of recurrent major depressive episodes. She's up, she's down, she's back to normal, she's back down, and she's tired of it. In the movie, it will show how she's got everything planned. All of her clothes are wrapped together in the closet. Okay? Anne Bancroft finally looks at her and says, "Well, I'm just going to call the police." And Sissy Spacek grabs the phone and says, "Mama, if you do that, you'll just force me to kill myself now. Please don't cost us the last evening we have together." One point, Sissy Spacek takes her watch off, gives it to her mom, and says, "Give this to my kid." She says, "He'll buy drugs with it." Sissy Spacek says, "Well, tell him to get good drugs." Anne Bancroft says, "You're not even going to stop him from doing drugs." She says, "Oh, Mom, if I could stop him from doing drugs, I'd stick around to do that, but I can't." Okay? It's a horrible little movie. It is not recommended for a first date. Okay? But sometime when you're otherwise feeling miserable, you might want to check the movie out and watch it. My ABPSYC students hate me for showing it to them, but it's a very good depiction of suicide and the planning that goes into it and the desperation of people that finally decide to do it and why you, in fact, see their affect brighten once they've made the decision to kill themselves because it's finally going to be over, and that's such a relief to them, okay? We also have a disorder called adjustment disorder with depressed mood. With adjustment disorder, patients are sort of tripping through life and a stressor occurs. The stressor occurs, they get depressed as a result of the stressor. In order to diagnose an adjustment disorder, they have to have had a stressor, and their reaction has to be in excess of what you would expect. The criteria in excess of what you would expect is somewhat vague, but normally the way that's conceptualized clinically is that if the patient has had is having a reaction of such severity that they are seeking you out for therapy, that's probably in excess of what you would expect, because you would expect most people to endure stressors and continue happily tripping through life, okay? Then we have a disorder called dysthymia. With dysthymia, patients go down, frequently not as far, but they stay there longer, 2 years in order to get the diagnosis. Now, you all have known dysthymic folks. They're great fun to have around. They're great fun to invite to a party. You know, Days like today are really the worst because this morning I'm such a good mood, and look at all of you, you're so bright, and it's going to be so much fun. But this afternoon, when it all turns bad like it always does, it's going to be that much worse because it all started so good. Oh, dysthymia. Then we have some folks that like more variety in life, the bipolars. So they sort of like to swing in both directions. They will go up here and have wildly creative manic episodes, come back down and play normal for a while, and then go down and get depressed. Back around. Normally 3 to 5 cycles a year, okay? Then we decided that there's another type of bipolar that doesn't go quite as high as the manic, goes to hypomanic levels, and they swing sort of in here. And again, 3 to 5 times a year. And we decided to name that type type 2 bipolars. Now, I think you will clinically see some differences in behavior between type 1 and type 2 bipolars. But keep in mind, in DSM, there's only 3 diagnostic distinctions between these two. Distinction number 1 is that to have a bipolar type 1 episode, you have to have 7 days in a manic episode. Okay? For a bipolar type 2, you have to have 4 days. So it's 4 days versus 7 days, the duration of the manic episode. The second criteria is that if you are ever psychotic in your manic episode, you are automatically a type 1. And the third criteria is that if you are hospitalized at any time in your manic episode, you're automatically a type 1. So if you're creative enough to get hospitalized on day 1 of a manic episode, you're already a type 1. Otherwise, you have to have 7 days in your manic episode. So DSM only looks at 4 days versus 7 days, psychosis or no psychosis, and hospitalized or not hospitalized. It's the only distinction. Now, in addition to that, I think you will see some quantifiable other distinctions in type 1 and type 2. I think type 2s just go, they're more creative. They go more manic-y, okay? I think if you evaluate the 3 S's, you will usually find what you need to give yourself the evidence that this person is having a manic episode, okay? The 3 S's are sleep, sex, and spending. Regarding sleep patterns, a good type 1 bipolar will tell you they're not sleeping at all, or they're sleeping 30 minutes a night. A type 2 bipolar will tell you they're sleeping 2 or 3 hours a night. Keep in mind, there's some normals that really claim they only need 4 hours of sleep, okay? So evaluate sleep patterns. The second S is spending. Bipolar type 2s will overspend their budget. They're in constant problem with budget. Bipolar type 1s normally have budgets that are destroyed. They're well past bankruptcy. And they're not doing spending sprees like you and I do spending sprees. They're not going out and buying a $500 suit that they didn't plan on buying. They're making the same sort of money we're making, and they're going out to Dillard's dropping $12,000 on clothing and then taking it down to Salvation Army because the commercial said those people needed the clothing so badly. Wild spending sprees. Sexual behavior. Type 2 bipolar might have an affair, might do something too wild sexually. Bipolar type 1s, these people are having more creative sexual lives than you ever fantasized about in adolescence. 27 sexual partners in one weekend, all unprotected. And and as you listen to them, you get a sense they really did it. This isn't puffing, this is for real, okay? So if you will evaluate sleep, sex, and spending, you'll generally find the criteria you need for bipolar if it's there, okay? One of my favorite hobbies is Amtrak. I enjoy taking the train whenever I can. I always feel like, however, that I should get 3 hours of ABPSIC credit for having taken Amtrak. You know how we used to do Greyhound therapy? We're now doing Amtrak therapy. Now, if you go on Amtrak, you will find out that a ticket from here to Chicago is going to cost you about $45, and if you have a bedroom, it's going to be about $350. You should get the bedroom. It will give you a private space to run to, because you will really get tired of the characters that you will encounter on Amtrak, okay? A couple of years ago, I was on Amtrak. I go down to the smoking lounge, and I encounter a guy down there named Cowboy. Cowboy knows the answer to almost any question you could possibly think of. And Cowboy is sitting down there smoking. So I have my going to bed cigarette. I come back upstairs and go to bed. About 3 or 4 o'clock in the morning, the train ride got rough, so I woke up, decided to go down and have a cigarette. There sat Cowboy. Ashtray now about half full. I have my cigarette, I go back to my bedroom, finish sleeping for another 3 or 4 hours, go back down to the smoke car to have a cigarette before breakfast, and Cowboy is still there with an ashtray that's now overflowing. I look at Cowboy and I said, "You didn't sleep much last night, did you, Cowboy?" And he said, "Sleep? Sleep is the most inefficient activity that any human being can involve themselves with. Bipolar type 1 until proven otherwise." The following night, I go to the lounge car to order a glass of wine. Cowboy walks in about 10 minutes after me, walks up to the bartender and says, "I want a bud." Bartender says, "Not only are you not getting a bud, but if you don't leave this car immediately, I'll have the conductor put you off at the next stop." I thought, how rude. And then what I realized is that Amtrak may know Cowboy better than I know Cowboy. And they know that they've played this Bud Light game with him before and they don't want to go there again. Okay. One year I was on Amtrak and this guy was wearing these little metal hats. They were little pieces of metal all glued together. Okay? And he had several hats and it was around Christmas time. One of the hats was even red and green. Okay? But he's wearing this. As we got off the train in Denver for about a 30-minute layover, I hear him yell at the conductor and said, "What do you think of microwaves?" Conductor says, "It cooks food fast." He says, "It also boils your brain. You've got to protect your brain from microwaves." Okay? We get back on the train. I'm teaching ABPSYC at the time. I'm sitting down at that point in life, I was teaching ABPSYC. I go back down to the lounge car, and I'm sitting there with my camera, and I would love to get a picture of the back of Mr. Microwave Head's cap, okay? Because my class would love this. I'm sitting there at the table, and I'm talking to a kid who's probably 10, 11, 12 years old, and he has sort of sought me out because he's figured out there's a lot of crazies on this train, and this man looks reasonably sane. Well, about that time, Mr. Microwave Head walks into the room, sits down with his back to me, which was perfect, and I grab my camera, I take my shot, and I put the camera back down. And this kid looks at me and says, "Did you just take my picture?" And I said, no, I was taking a picture of some of the scenery out the window behind you. And he says, "Okay, I have to go now." So this poor kid had finally realized that he found a sane person, and then all of a sudden this dude pops out a camera. And when I had the picture developed, Mr. Microwave Head is in the background. But right here, dead center of the picture, is this kid looking at me. But it does not impair my social or occupational functioning, okay? Okay. Then we have cyclothymia. Cyclothymics have mood swings that are higher than normal mood swings, but not high enough to be qualified as a type 2 bipolar. So they're going to be swinging in here. To be honest with you, I have never diagnosed a case of cyclothymia because I understand where hypomania begins. If your mood swing is so high that it's getting you into trouble, that's hypomanic. Okay? I sort of believe that you're entitled to whatever good mood you can find as long as it doesn't get you into trouble. Okay? So when people tell me that their mood is swinging too high, I inquire about the 3 S's, and I require, what's the problem when you're in such a good mood? Tell me what the problem is with that. Well, it just feels uncomfortable because I feel happier than happy. Okay? Are you still getting things done? Oh, I'm getting a lot done. Are you getting into any trouble? Any encounters with the police department? Anything like that? No. Is your spouse complaining about this? Oh, no, they find me real energized. See, I don't know why this is a problem. Because people with normal mood swings will say, "Wow, I wish I didn't have all the ups and downs." Well, I guess me too, but if I didn't have them, life would probably be boring. So I have some difficulty understanding where the space is between normal mood swings and hypomania. I'm not saying that this disorder doesn't exist. I think it does exist. I just haven't diagnosed it. And I guess the place to diagnose it would be when your patient is really complaining of mood swings that are uncomfortable for them, but yet they're really not getting in any trouble with the mood swings, okay? Then we have mood disorder with psychosis. It's sometimes difficult to distinguish a mood disorder with psychosis from a schizophrenic disorder or another psychotic disorder, because psychotic disorders also involve mood issues. DSM says that there's two tests that you can apply to distinguish between a psychosis and a mood disorder with psychosis. The first test is that if the patient has a mood disorder with psychosis, it should be the case that the psychotic content arises out of the mood state and is consistent with the mood state. Now, over almost 20 years of practice, I had one patient that was polite enough to meet that criteria for me. This was a woman whose father had died, and she was grieving his loss. He had not been the best father in the world, had been physically and sexually abusive to her, had sexually abused her from age 5 to age 15. He died. She was grieving his loss. And as she looked in wood grain things, she would see her father burning in hell. Now that's an illusion, so it's really not schizophrenic in nature or psychotic in nature, but then that changed to the point that she was actually hallucinating her father burning in hell. Okay? Notice how the psychotic content arises out of the mood state and is consistent with the mood state. That's a nice, clean mood disorder with psychosis. But I have a lot of mood disorder with psychotic folks that are hallucinating voices from Jupiter, and I'm not sure where that fits in. So DSM says there is a second test that you can apply that I actually find much more useful. The second test says that when your patient is up here, manicky, they may be psychotic. When they're depressed and down here, they may be psychotic. But when their mood returns to the normal place, like all mood disorder patients will, the psychosis completely disappears. So when they're operating in the normal mood place, there's no psychosis. They're psychotic up here, psychotic down here, but not here. Now, if you get them here, and they are still psychotic, and that psychosis goes on for at least 2 weeks, you've now met criteria for schizoaffective disorder. Okay? So, mood disorder with psychosis. They may be psychotic at the poles. They're not psychotic when they're in the normal place. If you are impressed with a mood component, either way too much depression or mania, and they stay psychotic in the normal place, then that really meets criteria for schizoaffective disorder. Okay? Let's go back and take a look at some of the symptoms of some of these disorders. And it becomes important to focus on the symptoms because when we talk about cognitive behavioral treatment of these disorders, what we're really looking at is making interventions that reverse the effects of the symptoms that we're seeing. For example, these patients are frequently lethargic. They don't move around a lot. Therefore, we want to make interventions that get them moving because movement really is the enemy of depression. Okay? If you've got a patient that's depressed and you can get them moving, doing something, you're on the right path. I've had depressed times in my life that friends come over to my house and say, come on, we're going to go to a movie. I don't want to go to a movie. I don't feel like going to a movie. I know you don't, but we're going to go anyway. And they drag me kicking and screaming to the movie. Now, once I'm at the movie, I feel better than I did when I was at home. Just getting me out of the house, change of environment, something, okay, getting me moving. Runner's high, okay? You want to buy into a biological explanation of depression? There you go, get moving. Get the brain chemicals going, okay? So major depressive episode. Over at least a 2-week period, the patient has to have had 5 symptoms. And one of the 5 has to either be a depressed mood or a loss of interest or pleasure in all or almost all activities. In addition to that, they need 4 other symptoms. That can include significant weight loss, significant defined as more than 5% of body weight over 30 days, insomnia or hypersomnia, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness, diminished ability to think, and recurrent thoughts of death. Okay? Criteria for a manic episode. There's a distinct period of abnormality and persistently elevated, expansive, or irritated mood. They must have at least 1 week in the manic episode, or less if hospitalization is required, or less if there's a psychosis present. And then they have to have 3 additional symptoms, which needs to include inflated self-esteem, decreased need for sleep, flight of ideas, excessive distractibility, increase in goal-directed behavior, or excessive involvement in pleasurable activities that have high potential for painful consequences. One of the chronic arguments that I've had with psychiatry is that I will stand there and watch a patient. We used to have an inpatient psychiatry ward in Wichita at the VA. They would be on the locked unit. They would wake up in the morning and their mood would be fine. 2 hours later, they'd be angry, agitated, going off on someone. 2 hours after that, they'd be fine again. I stood there and watched that day after day and thought to myself, classic borderline stuff. I mean, look at that rapidly shifting mood, valuation, ideation, classic borderline stuff. I would have a psychiatrist standing next to me that says, oh man, we really need to increase their lithium. Their bipolar is just really out of control. Bipolars don't cycle 3-4 times a day. Bipolars cycle 3-4 times a year. Okay? Now, DSM was not my friend when it added that qualifier of rapid cycling bipolar. But if you'll read DSM, a rapid cycling bipolar still does 7 to 9 cycles a year, not 2 or 3 cycles a day. Okay? Now, it is possible for you to see manic symptoms and depressive symptoms in the same bipolar patient during the same day. And if you see both manic and depressive symptoms in a bipolar patient the same day, that's called a mixed episode. Okay? But that normally doesn't continue staying both manic and depressed. You're seeing it because they're cycling from one to the other. They've been manic and they're now getting depressed. So you're seeing both symptoms. It's called a mixed episode. Diagnostic criteria for dysthymic disorder. A chronically depressed mood that occurs for most of the day, more days than not, for at least 2 years. The person would describe their mood as down in the dumps. For children, by the way, the 2-year duration becomes 1 year. While depressed, the person experiences 2 or more of the following: poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration, and feelings of hopelessness. During the 2-year period, they're never ever without symptoms for a period longer than 2 months. There's usually an early onset, and it has a chronic course. Now, it's possible that a dysthymic can then bounce down and also do a major depressive disorder, sometimes called double dipping or double depression or double trouble. Okay? Various theories of explaining depressive disorders. First of all, we have the psychoanalytic theory proposed by Freud and certainly agreed on by Erik Erikson, that people that are depressed fail to meet their nurturance needs during the oral stage. Nobody took care of them. Nobody took care of their needs during the oral stage. Or people overtook care of their needs. They got too much or too little during the oral stage. Psychoanalytic explanation. The behavioral explanation is that people normally get rewards for doing activities. For some unknown reason with depressives, those rewards drop out. And as the rewards drop out for activities, they stop doing the activities and therefore get depressed. The cognitive behavioral theory is that learned helplessness contributes to depression. We certainly see this with older adults. We put them in a position that you've worked all of your life and now you don't need to do anything at all for yourself. We'll do it all for you. Just ring this room bell key. And you ring it and nobody comes. So you start doing things yourself and they come down and say, oh, no, we don't want you to do that. Well, here's what I thought I would do tomorrow. Well, we've got some activities planned for you for tomorrow. So when they do try to set goals, we frequently have people that step in and interfere with those goals. They're being essentially told how to run their life in some cases, and it would be easy to see why someone in that situation would really be getting into a learned helplessness model a la Seligman and would get depressed. The cognitive model, Beck believes that negative thinking is associated with depression. And then there's a biological genetic explanation that some people just have a predisposition to depression and they have bad brain chemistry, bad blood chemistry in their brain. Now, I have been told for a number of years that I bear a strong resemblance to Tom Cruise, but I try to sway my thinking slightly from his, but it's fairly close. I do believe in some patients taking antidepressant medications, but as a general rule for my patients, I would much rather work with them not on antidepressants. And the reason for that is that I see antidepressants as having a very disempowering effect. Well-intentioned physicians will look at a patient and say, "Oh, honey, we're going to get you feeling better. We just have to get your brain chemistry in balance. And once we get your brain chemistry in balance, then you'll be feeling better. So don't worry about it." And then they come to me and I say, "You know what we need for you to do is to walk around the block this afternoon." "Oh, I really don't feel like it." "Oh, I know you don't. I don't feel like doing it either, but I'd really like for you to walk around the block." "Well, my physician says that he'll get my brain chemistry right, and then I'll feel like doing these things again. I'd rather wait until that happens." So I see antidepressant pills as being a very soft, subtle message to patients that you really don't have any control over this. It's your brain chemistry. Well, see, I think you do have some control over your brain chemistry. As I mentioned before, runner's high. You know, when I diet real hard, how many of you were at my seminar in November? None of you were here in November? That was videotaped also. Thanks. Thank you. There you are, Leanne. Do you remember me in November? I saw the videotape of me in November. I was a blimp. A blimp. Not that Mike doesn't take weight off when he does his editing, but he certainly added it on in my case. And I was appalled when I saw the tape. Additionally, between the time I saw the tape and I had taped, I had done seminars out of state, and during one seminar I had unbuttoned my top button, okay? Because I couldn't breathe. So I unbuttoned the top button and did the seminar that way. I decided it was either time that I go into size 18 shirts or it was time to lose some weight. And I decided to lose the weight. Leanne, since November, down 36 pounds. So I've been dieting hard, okay? I've been dieting hard, but when I diet hard, from time to time, my mood goes, okay? And when that happens, what I've learned to do, and you'll laugh at me, but it's really not for any other reason. I gain weight because I overeat dumb things, but I don't crave sweets. I'm not a big chocolate fan, etc. But when my mood starts to go down, I head to the candy bar machine, get a Hershey bar. And about 30 minutes after eating chocolate, mood comes back up again. So I feel in myself the effects of chocolate on brain chemistry. I mean, there's a connection there. So I believe in brain chemistry. I just think that there's things we can do to control that brain chemistry other than sitting around and waiting for the pills to take hold. I think that's disempowering, and I think it's more learned helplessness, you know? Yeah.
You said there was the psychoanalytic theory, and I didn't get the second one, and then the cognitive behavioral.
Second was the behavioral theory,
Okay.
that people are just driven by reinforcement, and for some reason those reinforcements for activity drop out. And if behaviors only get repeated that are reinforced, the behavior would stop being repeated at that point. Okay? So I think it's important that we teach our patients how to work on controlling their own brain chemistry. And it's also the case that with antidepressants, half hour or so after most patients take them, they feel this anxiety punch. Well, with the anxiety punch, they're supposed to get up, get dressed, and get moving. A lot of patients will say, "Oh, I just feel so nervous, though, so I'm going to wait for that to pass before I do anything." Oh, it's self-defeating. The purpose of the punch is to get you up and get you moving, okay? So you've got to work a little bit with the antidepressants. I have a physician here that refers business to me, and for the longest time he would write, Zoloft 50 milligrams a day times 7 days, then 100 milligrams a day, consult Dr. Tom. Okay? I told him one of two ways of doing this. Either consult me and let me have a throw at him for 30 days, or put him on the Zoloft, wait 3.5 weeks, then consult me, so that I can come in and work with him one time and claim credit for the recovery. Either way you want to do it. Okay? And so he stopped doing the Zoloft and the Dr. Tom at the same time. So he'll consult me. After 30 days, if I can't see some improvement in this patient, I'm the first person in the world to go back to the doc and say, okay, why don't you add some of your drugs? You know, I mean, I just want a shot at doing this without drugs. Because once they're on drugs, they normally feel more disempowered. Oh, wow, there is a problem. I've got to take a pill. Well, I'll wait for the pill to make me feel better. Well, the pill may make them feel better, but it's certainly going to work much, much better if they'll cooperate a little bit along with this pill. Okay? Okay, the symptoms of depression we can really sort of cluster, and I'm on page 4. I have to. You're all I've got. Page 4, symptoms of depression. Emotional symptoms. Patients feel intensely sad and dejected. They describe themselves as feeling miserable, empty, humiliated. They also experience anxiety, anger, and agitation. They lose feelings of affection for friends and relatives. They have complaints of boredom, feelings of guilt. Motivational symptoms. They lose the desire to participate in their accustomed activities. A lack of drive, initiative. They force themselves to go to work. Difficult to converse with friends, eat meals, or have sex. And they become indifferent to life and wish to die. Behavioral symptoms. Their activity decreases dramatically. They tend to spend more time alone and in bed. They move more slowly with reluctance and a lack of energy. Crying, withdrawal. They may hallucinate if they have a mood disorder with psychosis. And then the cognitive symptoms. They hold a negative view of self. They consider themselves inadequate, undesirable, inferior, maybe even evil. They feel unattractive or repulsive, and they have feelings of hopelessness and helplessness. So as we look at treatment of some of the depressive disorders, what we look at is some of the symptoms. For example, one of the essential symptoms is that the person loses interest in their daily activities. One of the strategies that I use with older adults, when I work with them, I will say, this week I would like for you to go to 4 groups. And I really impress upon them that some of the groups really suck. And if they want to go spend 5 minutes and say, this isn't my cup of tea and leave, that's fine with me. I just want them to make an appearance. But some of the groups are very worthwhile. I'll go back the following week, talk to the activity director and say, did so-and-so show up in a group? No, and we encouraged them like you asked us to, but they just wouldn't go. So I'll go to the patient and say, did you go to the groups this week? No, I just didn't feel like it. Okay? And I'll look at them and say, you didn't feel like it. No. I'll say, do you really have to feel like doing something before you do it? Well, yeah. I say, really? You think I felt like getting up this morning, taking a shower, putting on a suit, and driving all the way across town to see all of you folks? No, I just did it. Now, once I'm here, I'm glad I'm here. But if I would have waited around to feel like doing it, I mean, how many of you really felt like getting up this morning, coming to a 9-hour seminar? No, you paid your money, you need your CEs, so you'll come, but you didn't feel like coming here. You know, this whole did you feel like it thing, intervention came to me in a very odd way. I have a friend that lives in the South. At the time, she had been married for about 23 years. She called one day and she says, you know, my interest in sex has just gone down to 0. I mean, and it's been going on for a long time, and it's really starting to have an influence on my marriage, and I don't know what to do. And I said, oh, I think you ought to touch base with your family physician about it. She goes to the family physician, and the family physician says, okay, so you've lost interest in sex. She says, yeah, I really have. I just don't want to do it at all. And he says, who said you had to be interested in having sex in order to have sex? You just do it. Now, it may force your spouse to work a little bit harder to get you aroused, but you don't have to be interested in sex to have sex. I thought that was a very cold intervention on his part. Okay, I thought he could have warmed that up a bit. Okay, but I've stolen the intervention from him to use with depressed people. I wouldn't use it with your sexual disordered patients, but I think with depressed people it's good. By the way, he also put her on medication. He placed her on testosterone. She was on testosterone for about 3 weeks. She said she became a flaming bee. She was throwing things. She was breaking things. She slapped her husband on one occasion. And she finally took the medication, threw it away, and says, I will never take this drug again in my life. And I looked at her and I said, and you thought it was easy for us, didn't you? Regarding that road rage crap, get off our back. We're holding together as best we can. So I've stolen the intervention. I think it's very, very effective for depressed folks, and I find that it helps probably 30% of the time or so. We'll talk more about treatment stuff. Any questions, comments? Okay, if you're watching this as part of the educational video, at this time what I would like for you to do is to go into DSM-4TR and read certain aspects of depression. The pages that I would like for you to refer to are pages 345 to 385. Take about 20 or 30 minutes, review these. You can scan that first part and go on into the bipolar disorders if you'd like, and then turn the tape back on and rejoin us at that time. Thank you very much. Taking a look at some treatment possibilities for depression. I would remind you of Albert Ellis's old ABC model, where an event happens to us, and following that we feel some type of emotion or feeling state. So my girlfriend breaks up with me, and I feel sad. And it was Ellis that says, you know, actually your girlfriend breaking up with you isn't what made you sad. What made you sad was the B in between, which was your interpretation of the event. So actually what happened is my girlfriend broke up with me, and I then said, oh my gosh, another woman's broken up with me. This clearly means that I will never ever have a relationship in my life and I'm destined to die alone. And then I felt sad. So what I'm really feeling sad about is the B part. And Ellis contended that the B part can always be challenged, and it can be. It's the event that people put on things. The other day my mom called me and she was real upset because the neighbor next door said, you let your dog out every morning at 4 o'clock and your dog comes to my window and barks. Can you wait to let your dog out until 6? Because we really don't want to be awakened at 4 o'clock in the morning. That seemed reasonable to me. My mom was just off the wall about this. Well, my gosh, I just can't believe this. This is just awful. She just can't control my dog, and after all, she's always said that she liked my dog, and clearly she doesn't, and I just don't know that I want to live next door to somebody that hates my dog. Oh, the woman never said she hated the dog. She says, would you mind keeping the dog in until 6 o'clock in the morning? You got an adorable, beautiful dog. I don't want to bark at 4 o'clock and waking me up. But see, the interpretation my mom is putting on that is that the neighbor clearly hates the dog. Okay? The B. Okay? Now, you all may be able to intervene in her B. I can't. Try. Now, I did become a psychologist because of it, but I'm still not very successful in my interventions. So in essence, the treatment for depression addresses the symptoms of depression, challenging the thinking. What meaning did you really give to this? Encouraging activity. Inactivity, movement is the enemy of depression. By the way, I'm now on page 5. See, I can count on you. Typical problems that depressed folks have. They have problems with decision making. I think it's very important to remind patients, and sometimes to remind ourselves, that when it comes to decision making, some of the decisions that we get wrapped up with don't matter. There's no right or wrong decision. They're just choices. They're just pick one. Do I want to wear the pinstripe suit or do I want to wear the gray suit? It doesn't matter. This morning I stood there and said, the purple shirt or the pink shirt? Isn't there something about pink before Easter that I'm not supposed to do that? But I'd really feel more comfortable in the pink shirt, and I end up wearing the purple shirt because I'm not sure about this pink before Easter thing. But that may be shoes, I don't know. And my pink shoes are all scuffed up anyway. But some decisions don't matter. When decisions don't matter, just pick one. And we need to encourage our patients to just pick one. Now, there are a couple of strategies that I thought were fun that I found while reading along on some of this stuff the other day. One of the strategies is to encourage your patient to use an alphabet method. If they can't decide what dress to wear in the morning, use the alphabet method. Whichever one comes first alphabetically, you should wear. So if you can't decide between the blue one, the green one, the red one, or the yellow one, you wear the blue one because it comes first alphabetically. Now, the next time you can't make the decision, you go to the next one in the alphabet, which would be the green one, okay? Another technique that I don't have a coin. Another technique that I saw the other day that was sort of cute is a patient says, gosh, I can't decide between going to K-State or going to KU. So you look at the patient, you pull a coin out of your pocket. And you say, okay, well, let's say that heads is KU and tails is K-State. And you flip the coin. When the coin comes down, you say, what do you hope it landed on? And they say, well, I really hope it landed on tails. And at that point, you take the coin and put it in your pocket. Decision's made. Coin flip method. Okay? You can also work with patients on just listing pros and cons. You know, what are the pluses and the minuses of both of these decisions to be made? So there are ways of teaching sort of decision-making strategies, keeping in mind that many decisions that our patients obsess with and many of the decisions that we obsess with don't matter. Burger King or McDonald's for lunch, it doesn't matter. Okay? To me, it matters. My only option is Subway. That's why I'm so damn dysthymic. Okay? Helping patients get better organized, helping them to plan, prioritize, delegate tasks, helping them to stop assuming control for other people, how to get them to combine and condense activities, how to get them to focus on one task at a time, problems getting lost in thought, having them understand their own time preferences. You know, we all have time preferences. I actually wake up pretty good in the mornings. If I have some task to do, first thing in the morning with my cup of coffee is a good time for me to hit it. Other people, not so much. They'd rather do stuff late in the day. Well, find out from your patient, what are your time preferences? You're more of a morning person, you're more of an afternoon person. That task that you're just dreading doing, maybe you want to do that at the bright time of your day. Maybe you don't. Maybe you want to do it at the worst time of your day. If the task is really horrible anyway, it's probably going to bring you down. You might as well save it for the time of the day that you're down anyway. But they have some choice. But they have to do these tasks, you know. So just sort of talking through with them and helping them get prioritized and finding out when's your preference for doing these things. And what does your body do? You more of a midday person? You more of a morning person? You more of an evening person? Helping them do a time management study to minimize unpleasant tasks. Maybe to clump the unpleasant tasks together. Maybe to break them up. You know, if I got a whole bunch of unpleasant stuff to do, I'd just soon do it back to back. Get it all over with. Instead of blowing my day doing one unpleasant thing, then doing some fun things, then an unpleasant thing. But it's preference. And you know something? We have choice. We have control. And once we see patients start exercising choice and control over some of these minor things, depression tends to lift because they're now realizing they've got some choice and control in their life. If they have concentration or memory problems, trying to help them eliminate obsessive thoughts. Sometimes you can teach them to use like a stop-it technique. Other times, tell patients, you know, you need these obsessive thoughts, but they're interfering with your day. So what I want you to do is to sit down at 5:30 every evening, and from 5:30 to 6, I want you to obsess. I want you to do nothing but obsess from 5:30 to 6. And at other times during the day when you find yourself obsessing, stop it, put it on a list, and deal with it 5:30 to 6. And I've had more than one patient come back to me and say, you know, it's really stupid for me to do that 5:30 to 6 obsessing. I don't see the point of it. Of course, I guess I don't see the point of doing it all day long either. Some nice cognitive restructuring taking place all on their own. You know? Changing stinking thinking, helping patients have realistic cognitions that increase hope, which increase self-esteem. Reminding patients that you choose your own lens. You can look at something and see all the positives. You can look at something and see all the negatives. Sometimes to keep a positive things journal, having them keep a journal of the positive things that happen. Because when we're having a bad day, we don't tend to notice the positive things. You woke up late this morning. You went to put on your outfit. It doesn't fit. So you start your trip in here 15 minutes late. You're trying to catch up time. You get stopped and you get a ticket. You finally do get here. You take the wrong turn and end up doing a tour of the airport twice. Okay? It's a horrible, miserable day, and you're really mad about it. But you know, the car started. You didn't get in an accident. You didn't rip your outfit. And you did get here. There's positive things happening, but we tend not to see them because our day becomes so clouded with negative things. How many of you toured the airport at least once this morning? That's not bad. There's about 5 hands that went up. When we do seminars here, we get that all the time on evaluations. Include a map of how to get here. A map of how to get here wouldn't help a bit. Other symptoms of depression: feeling overwhelmed, keeping it small and simple, limiting projects to help build self-esteem, limiting to 5 tasks at a time, and having patients do effective goal setting. I think goals are very important. They remind depressed people that there really is action that they're seeking and there really is something they can do. I love weight loss goals for anybody, especially depressed folks. I love weight loss goals because if you'll just play the game and follow it for 2 or 3 days, you'll see a pound drop on the scales, which means you do have control. You can control this. Okay? So you turn your depressed patients into good little anorexics.
Will you ever tell us how you lost the weight?
You know, I just did calorie counting. And see, I'm on the road so much, and that's killer for me. So I do a lot of Subways. And I always have a Subway sandwich in my cooler, and if I get hungry, I take a couple of bites of Subway sandwich. I still go out for my steak and lobster. I don't do the baked potato. Love baked potato, but by the time I finish doing a baked potato, it's 700 calories. I mean, I load it with butter, sour cream, onions, bacon bits, and cheese. So I've learned, go to the steakhouse, order the steak, no potato. When they say, well, have your bread right out, I say, skip that too. And you know what I found out? I had forgotten how good steak tastes. Because I was eating my salad, rushing through my steak, and then going to the baked potato. It was almost like the baked potato was my main entree. Well, without the baked potato, I really enjoyed the steak much more. So that's how. And the speed. No. But effective goal setting. I think it's just real important, especially for depressed patients. Be encouraging and have them set goals that are small, measurable, and accomplishable. A goal to do 2 activities this week, not a goal to be happier. You can't measure be happier. Furthermore, you don't know how to do it. You know, measurable goals. And finally, procrastination. Depressed folks tend to procrastinate on tasks. I'm going to do it later. Well, let them say that. Hesitate a couple of minutes and say, it's later now. Is now the time you had in mind? You know, a rule that I like to sell to depressed people because I find it so effective in my life, the 5-minute rule. I set a time that I'm going to do an unpleasant task. Mine would be dictation. Remember, Glenda? I hate dictation. So I will say, okay, at 5 o'clock tonight, I'm going to do dictation. And at 5 o'clock tonight, I have to do dictation. But I don't want to. Well, 5-minute rule. I have to do it for 5 minutes. Now, after 5 minutes, I have an option to stop. But I have to do it for 5 minutes. Well, after 5 minutes, I'm already on it. I'm on the roll then. So now I'll go ahead and finish the task. You know, I will go into my weekend knowing that I've got a month of dictation to do. And I will wake up on Saturday and not be able to do anything because I've got to get that dictation. Saturday afternoon, I'm still not doing anything because I've got to do the dictation, but I just can't sit down to do it. I blow Saturday night too, and proceed to go into Sunday and blow that day also. And finally, at 9:30 Sunday evening, I will sit down and do the dictation, and it takes 25 minutes. I've blown an entire weekend with a task that I've put off, and I wouldn't let myself do anything else because first thing I have to do is dictation. 5-minute rule has been very effective for me. And I think it's very effective for patients to say, you just set a time and you do the task. Well, suppose I don't want to do it then. You have to for 5 minutes. And after 5 minutes, you've got an option to stop the task. And I've seen it work real well. It works real well with me and my dictation. Strategies that you all have found that you found particularly helpful in treating depressed folks? I gave you coffee. You're going to get a donut at break. That better turn some things around here. Yes.
Well, I use what I call it taking your thoughts captive. It's simply a cognitive piece where you look at the thought you have, you look at the feelings, and then you move from the feelings to the truth or fact.
Taking your thoughts active? Captive. She uses a technique called taking your thoughts captive, where you take a look at your thoughts and then you just sort of tear them apart, evaluate them, and look at the feeling associated with it. Yes, ma'am?
What I tell them is to, whenever they have a negative thought, they have to counterbalance it with two positives.
Okay. Every time you catch yourself having a negative thought, you've got to force yourself to have two positive ones. You know, which would be very similar to the strategy used by a positive thoughts journal, to focus them a little bit on the fact that positive things are happening. Now they're getting lost because of the negatives, but they're still occurring.
Have them at times kind of ask that question, am I in the room? Am I present in the room now with my thoughts? Rather than being
On
in
automatic.
the past, focusing on what happened this morning or...
When she catches a patient doing stinking thinking, she has the patient ask the question, am I present in this room now, or am I focused on yesterday? Am I focused on what happened in the past? What's going to happen in the future? Am I in the room now? Giving them more of a present focus instead of ruminating about other things. Right. Good. Mike?
And when we're in session or when they're in a good mood, I have them write down things that make them feel good, from things that happened to chocolate ice cream to puppy kisses. When you get up in the morning, hang it right by the bathroom. So you know you're going to have to pass it and just go by and go like this.
Oh, I like that.
Look up and see what it is. And, you know, and if you still don't get it, you just poke another one and see what it says. You know, kind of close your eyes and pick it.
He has patients write down things that feel good, from nice things people have done to them, to ice cream, to a sunshiny day, and he has them write all that down and then post it in the bathroom where they'll see it every morning. And every morning they have to look at something on the list and pick something out of the list, and if that doesn't do it, they have to go to something else. Nice little reminders that life doesn't always suck, just sometimes, you know? Good. Thank you guys for sharing those. So what's the curative idea? Okay. Maybe next seminar we'll do that one. I think the thing that comes closest to a cure is just activity. Get them moving. You know, get them moving and evaluate some of that thinking stuff. Okay? Any lingering questions from the depressive disorders? Okay, we're going to bounce right into the anxiety disorders then, and I think that puts us on page 6. Keep in mind that there's 3 basic components to anxiety. First of all, there is a subjective report of tension, apprehension, sense of impending doom, or expectation of inability to cope. But reality testing is not impaired. Matter of fact, it's been said that these folks are painfully in touch with reality. Okay? Second, there's a behavioral response, such as avoidance of a task, impaired speech, impaired motor functioning, or impaired performance on complex cognitive tasks. And third, there's a physiological response, including muscle tension, increased heart rate, increased blood pressure, rapid breathing, dry mouth, nausea, diarrhea, or frequent urination. Okay? Now, we have three main categories of anxiety disorders. We have manifest anxiety disorders, dissociative disorders, and somatic disorders. And my conceptualization of these is that they sort of fall on a continuum, where people with poorly managed anxiety end up usually with a manifest anxiety disorder, that if it doesn't get managed, ends up going into some type of dissociative disorder or somatic disorder. The exception to that conceptualization would be the dissociative identity disorders, which I really see as probably arising out of early childhood trauma more than mismanaged anxiety. So dealing with some of these. First, we have an adjustment disorder with anxiety. An adjustment disorder with anxiety is that when someone is merrily tripping through life, they encounter a stressor. As a result of that stressor, they become worried, they become tense, they become fearful. But the type of stressor that they encountered is a common, everyday type of stressor, garden variety, of the type that most of us will encounter. Diagnosis, adjustment disorder with anxiety. Now, if the type of stressor that they encounter is of the catastrophic variety, the type that most people will not be exposed to, and the type that involves threat to physical integrity or loss of life, and from which escape is not possible, then the appropriate diagnosis becomes post-traumatic stress disorder. Now, doing evaluations for post-traumatic stress disorder can be very difficult. The reason that it's difficult is that these evaluations almost always involve somebody receiving some type of compensation. So they want the diagnosis. They've been in a car accident, they've been exposed to some situation that if you will give them a diagnosis of post-traumatic stress disorder, they will be financially enriched. The last thing in the world that you ever want to do is to deny someone a PTSD diagnosis that truly has PTSD. But it's difficult to know because they all come to the evaluation prepared with the symptoms. They know the symptoms. They're available on the internet. They're available in abnormal psych texts. Their friends will tell them what the symptoms are, or their lawyer will lead them to the symptoms. So they all come in complaining of nightmares, flashbacks, intrusive thoughts, survivor guilt, and concentration problems. So how do you know who's for real and who's not for real? Well, one of the things that you can do is to evaluate the stressor. Because many times when you evaluate the stressor, you will find out that the stressor is not of the severity that DSM intended when they talked about threat to physical integrity, loss of life, and from which escape might not be possible. Okay? I did C&P exams at the VA for a number of years. If you want to encounter a catastrophic type stressor of the variety intended by PTSD, of DSM for PTSD, being in the military is a real good place to find one. Okay? They have a number of them in there. Okay? So being a combat vet where you're standing there shooting at somebody and your buddy's standing next to you and he's gun jams and he hands you the gun and says, "Would you unjam this for me?" And while you're working to unjam it, he gets blown away. That'll do it. Okay? Rape, childhood sexual abuse. Being in a car accident can do it, but if you're going to convince me you got it from a car accident, I really want to see you trapped in the car, and it would be helpful if the car would catch on fire. Okay? I don't think you get it from a fender bender. Okay? Fender benders are unnervy, but you really shouldn't get nightmares and flashbacks from it. Okay? Sometimes you don't particularly feel good about the work you do in giving or not giving a PTSD diagnosis. I had a legal case. It's been 3 or 4 years ago now. This also is a good earmark for my being the end of my forensic career. And it demonstrates how legal cases take on a life of their own. This woman had been in a car accident. She was in a car accident, and after the car accident continued to experience headaches. Her attorney referred her to a neurologist to be worked up for the headaches. The neurologist certainly proceeds to have her get undressed and get into one of those very comfy physician robes. Okay? He then proceeds to do a breast exam. Very important to do because, see, headaches can be caused by brain tumors. And brain tumors normally metastasize from breast. So you have to do a breast exam to make sure there's no tumor there. Okay? Now, while in the robe, he proceeds to examine her pubic hairline. Also has great significance. Yes, ma'am.
I know this doctor's name.
also has great significance to a neurologist, and this turns out to be absolutely true, and I never knew it. There are certain neurological disorders that if you are a female, your pubic hairline will change and you will have a male pubic hairline. And if you're a male, you'll have a female pubic hairline. Apparently they're different. So to examine pubic hairline is important to a neurologist because it rules in or rules out certain neurological disorders, which I never knew, but apparently that's absolutely true. Well, apparently while doing this exam, the physician also sees fit to ask her whether or not she's multi-orgasmic, and whether or not she has difficulty reaching orgasm, and which position she finds most helpful to have an orgasm, and is that the same position that her mother liked? This goes on and on and on, to the point that she stands up, gets dressed, and leaves. Okay? Goes back to her lawyer, and the lawyer says, well, I may want to send you to another neurologist. She says, really? I may find a different lawyer then, because I'm not doing that again. He says, wow, really? So this really bothered you? She said, oh, it bothered me a lot. He says, are you thinking about it all the time? She says, I am. He says, are you having a hard time concentrating on other things because of this? And she says, that's correct. He says, you're not having nightmares, are you? She says, well, as a matter of fact, this doc did come to me in my dream the other night. He says, oh, my goodness, I think you've gotten PTSD from this neurological eval, so I'm going to refer you to a psychologist. So refers her to a psychologist that gives her a diagnosis of PTSD based on this eval. Well, I have some reputation in Wichita as being fairly hard with the diagnosis of PTSD. So I get the referral on the other side. I evaluate this woman. Evaluating the woman, I find her to be mildly histrionic on testing and on presentation. And I explain to the jury, there's mildly histrionic, which means fun to be around, life of the party. And then there's histrionic, which means you can't believe a word she's saying. Well, I think she's mildly histrionic. And I lay this out. And I said, I do not believe that she has PTSD because the nature of the stressor for PTSD must be that there is a threat to physical integrity or loss of life. Now, I will give her threat to physical integrity. She may well have felt that. But then we have this piece of from which escape is not possible. Well, not only was it possible, she took advantage of it. So personally, I think what happened to this woman is horrible, but I don't think it's the type of stressor that the DSM intended for PTSD. So that was the conclusion I made. That's the testimony I offered. Now, where my legal career ended. I was very good on direct examination. I laid this all out to a jury. I taught the jury well, and the jury fully understood me. Her lawyer now stands up to do cross-examination, looks at me and says, gosh, doctor, I'm really sorry that you didn't have a good time with my client. I found her really fun. I'm sorry that this was so difficult for you to work with her. And I said, oh, no, I enjoyed working with your client. Oh, doctor, how could you have enjoyed working with my client? You didn't believe a damn thing she said. I said, oh, no, I believed her. He says, you believe that these things happened to her? I said, oh, yeah. Look at what I'm doing. I'm verifying his client's case for him. And I'm the witness for the other side. Well, as I'm doing all of this, the attorney that hires me falls through the floor. Okay? He gets back up under redirect and says, so, Dr. Tom, you believed this woman, huh? And I said, I did. He said, Dr. Tom, you'd be a psychologist, wouldn't you? And I said, that's correct. He says, matter of fact, you're a psychologist out of the Rogerian school, aren't you? And I said, yes, I am. He said, so you just essentially believe anything that anybody tells you anyway, don't you? And I said, yes, I think believing people is an important thing. He said, so, doctor, if I told you right now that I was Santa Claus, you wouldn't argue with me, would you? And I said, no, I wouldn't argue with you. That would be a good place to start in therapy. He says, that's what I thought. I don't have anything further for you. Do you know he's never called me back to do another case? Never called me back. You know, I think this stuff happened to this gal. I had no question about that. I believed her. It's just that I didn't think the severity of the stressor rose to the level to be a PTSD type stressor. So I was just testifying academically here.
What was the final outcome?
She won her case. She got a settlement from him, but I don't know what amount or anything. But, you know, legal cases will take on lives of their own.
If she was sexually abused as a child, would that not play a part?
Absolutely. Absolutely. Yeah. Under old DSM criteria 2 and 3, we didn't have to consider that sort of stuff, and we didn't have to consider how someone else, we did have to consider how someone else would respond to the stressor. Under DSM-4, we no longer have to consider how other people would respond to the stressor, because we've now learned people with different backgrounds, different makeup, are more prone to PTSD. You know, there was a time at VA that I used to get referral questions from the regional office that said, is this antisocial personality disorder or is this PTSD? Meaning if they had one, they couldn't have the other. Oh, no, it happens to be the case that if you've got antisocial personality disorder, you're predisposed to getting PTSD. But to claim PTSD because they have you confined in a prison for your acts is probably not a real convincing case. Okay? About 10 years ago, I was watching Judge Wapner. This is research relevant because I currently like Judge Judy. Judge Wapner had a guy walk into his courtroom that was suing a dry cleaning clerk for rude treatment. Don't understand. This was rude treatment that had interfered with his shopping pleasure. Okay? He comes to the courtroom accompanied by his mental health provider. Judge Wapner says, have you been treating this man? She says, I have. He says, for how long have you been treating this man and of what frequency? She says, I've been treating him for approximately 3 years, primarily 1 time a week, sometimes 2. And have you reached a diagnosis with reasonable medical certainty? She says, I have. I find that he suffers from post-traumatic stress disorder as a result of the rude treatment by the dry cleaning clerk. Judge Wapner didn't buy it. You all shouldn't buy it either. One of the ways of evaluating PTSD cases is to take a look at the stressor. You go down in your basement in a tornado and you watch your neighbor's house get blown away and you sustain loss of property. That'll do it. There's tornado warnings out and you went to your basement and you were so scared but it never developed. That won't do it. Okay? Something has to happen. Okay? And people will claim PTSD for things that they were afraid were going to happen. I don't think that does it. Okay? So they're tough evals to do because the last thing you want to do is cheat someone out of the diagnosis, but yet we can't go around diagnosing everybody with PTSD because there was a spot on their tablecloth and it was really bothersome to them. You know, there has to be...
Doctor, I didn't get that pony when I was 4.
I know. Exactly. Okay? Yes?
People that have been raped and people that are working with EMS, stuff like that, where they actually feel this stuff.
Yeah.
Even secondary PTSD from working with.
That's right.
Would that be a correct diagnosis?
Absolutely. Secondary PTSD, you weren't involved in 9/11, but you were part of the rescue team that went in there and rescued people. Absolutely. You know, the threat to physical integrity or loss of life can be you're witnessing someone else go through that as well. Okay? But the further removed you are from that, the less likely that you're going to get that diagnosis from me. You know, I mean, we all have to build our own case. We all have to say, here's what I'm going to buy, here's what I'm not going to buy, and where does the line get drawn? And every clinician tends to do that in a different place. And there's always a justification to diagnose someone with PTSD, but, you know, if everybody's got it, then it kind of sort of becomes meaningless, you know? So, now, do keep in mind that PTSD onsets 30 days after a stressor. It can onset 30 years after a stressor, too. But if you go through a stressful event, the reaction that you're having for the first 30 days is not called PTSD. It's called acute stress disorder, okay? An acute stress disorder means that you're in this building and all of a sudden the building collapses, and over the next 30 days you have nightmares about this. Every time you walk in a building, you check the foundation first, and you're constantly reliving this moment. For the first 30 days, we call that acute stress disorder. On day 31, that automatically becomes PTSD. So PTSD is a diagnosis we give after the first 30 days, okay? Then we have generalized anxiety disorder. With generalized anxiety disorder, somebody is feeling worry, anxiety, all of those anxiety symptoms, but there hasn't been a stressor. No stressor has occurred. Okay, they're just sort of feeling those in isolation for no apparent reason. I personally believe that that comes from years and years of mismanaged stress and frustration and anxiety. And I think that finally builds up to the point that that just sort of becomes someone's lifestyle. Now, people can have generalized anxiety disorder with or without panic. Okay? Panic disorder normally takes a couple of forms. Form number one, they feel heart attack symptoms. They feel chest pain. They feel shortness of breath. Type 2, they generally will feel sort of a dissociated state. They'll feel like they're not in their mind anymore. Not like they're going crazy, but like they're somehow separate from themselves, sort of a dissociation. And I'm sure there's other types of panic attacks. It is very, very important when patients say I'm having panic attacks to say, well, tell me what those are like. Because I've had a number of people say, oh, I have these panic attacks. And I say, what's that like? And they say, well, I just burst out into tears for no apparent reason. So panic attacks has sort of become the new word for having a nervous breakdown. People use it a lot, but nobody really knows what it means. You know, nervous breakdown could be a bunch of anxiety, it could be a bunch of depression, it could be a bunch of psychosis. And until you ask, you don't know. Okay? Then there are phobias. Yes?
I've always wondered, because you hear people that are much older, say like 70, 80, et cetera, that have had a nervous breakdown. And I always looked at the DSM-4 and said, what really was going on?
That's right.
So you say it can be a combination of several things.
When a patient tells you that they had a nervous breakdown, you need to look and say, wow, what was that like for you? What was going on? And then they'll tell you that they were hallucinating. They'll tell you they were so sad they couldn't stop crying, or they will tell you they were so nervous that they were passing out. You know?
But I guess what I'm asking is what, years ago, under the criteria, I don't think we had a DSM back then, but what would it be, what would be the equivalent of it today?
I think it's nonspecific. Yeah, I don't think there was ever a medical term called nervous breakdown. Okay? If I were to use that term today medically, I would say it means a psychotic break. But I don't know what, that's what I mean. When people say it, you don't know. You know, that's why you have to ask. Yeah.
I think that's a layman's term. I mean, for someone that is not educated in this field,
Right.
that's how they term their emotional discomfort at that time.
Yes. And I think the way you're hearing that being framed today is that I'm having panic attacks. And that can mean a wide variety of things too. You know. So when people say they're having panic attacks, don't just diagnose that, but ask them, what are those like for you? Well, I hear voices. See, that's a different kind of panic attack. Okay. Phobia is when a person has an anxiety reaction to a specific object. When they see the object, or they get presented with the object, or they get threatened to present with the object, they have an anxiety reaction to that. And then we have obsessive compulsive disorder, which is people attempting to avoid feeling anxiety by involving themselves in various sorts of thoughts, obsessions, or rituals, compulsions. So they go through life always worried about germs and washing their hands 75 times an hour in order to avoid getting sick. They're trying to avoid something, therefore they're involved in some obsessive compulsive ritual in order to avoid it. Okay? Next, we have the dissociative disorders. The first one is depersonalization. Depersonalization is sort of a strange thing, but having experienced this in my own life, let me tell you about my experience, and maybe that's the clearest way I can lecture about it. I started off my first year in adult life from 18 to 19, going to nurses training, and started off as a nurse at 19. The person who sold me my nursing medical malpractice policy told me that I was misplaced in nursing, and I should go sell insurance instead. So I became an insurance salesman at the age of 20. The person who hired me looked at me and said, I've never seen a 20-year-old succeed in the insurance business, and I don't think I'm looking at one now. That's all it took to motivate me. He didn't believe in me. Let me prove him wrong. I turned out to be a fantastic insurance man, and I worked my butt off to do it. I mean, out there at 7 o'clock in the morning, glued together with coffee, working till midnight at night. And I was a high-pressure guy. I mean, I really was. If you won't buy a 20, how about a 10? Did you want to use your pen or mine? Okay? I would be what you would term a high-pressure, hard closing salesperson. I really did get into the business because I cared about people, and I cared about families, and I cared about them protecting their financial interest. I really did. And I bought into all that stuff, okay? But what this turned out to be is night after night, day after day, me going out, sitting in front of couples, and there's going to be a winner and a loser. And if I walk out without an application, I lost, and I don't like to lose. So it was them saying no, and it was me saying, well, I understand that, but yes. No, yes, no, yes. I'm setting out talking to a couple one night when all of a sudden I felt myself, and I sensed myself on the ceiling, looking down, watching myself sell this policy. I wasn't freaked out by it. I didn't think it was weird. The interpretation that I made to myself is I'm really burnt out in this business. I got into this business because I cared about people, and look how burnt out I am. I am so burnt out that I can run on automatic. I don't even have to be inside my own body. I just carry on without me. And I was up on the ceiling looking down at what was going on. That was my interpretation at the time. Now, I now look back on that with the knowledge I have today. That's an absolutely classic depersonalization experience. You're watching yourself from outside your body, and the vantage point that you normally have is from up above, looking down on yourself, being engaged in some activity. Depersonalization comes from chronic levels of stress. Now, I look back on my years in the insurance business, and there ended up being a total of 5. I was hustling every single day. I was out there doing everything that non-successful people won't do. I did not have time to work out at the gym. I did not have time for recreational activities. I did not drink alcohol. I didn't do any drugs. I was doing nothing to manage stress. And there was a ton of it. I was $1 Million Round Table for 3 years, every day selling more than the day before. That was the goal. Beat the goal, beat the goal. Okay, got the picture? Over and over again. Went from depersonalization disorder, which I never did label as being anxiety until I look back on this 10 years later. And all of a sudden, I started having these weird sensations. Like I would be walking along throughout my day, and then all of a sudden I would feel drunk, but I hadn't had anything to drink. And everything that happened, I felt like I was in a barrel, and everything had an echo quality. And I felt like all the time I was about ready to faint, but I never did. So I finally go to my physician. He says, "Oh, you got an inner ear infection." And he looks and he says, "Well, I don't see anything. Must be hypoglycemia." I agree. It seemed a lot like that. Test me for hypoglycemia. That's not true either. I eventually ended up in a hospital for a week being fully worked up for everything. You know the final diagnosis I got? A typical temporal lobe seizure. What makes it atypical? Well, the fact that you don't have seizures and you have a clean EEG. Don't laugh. I ended up 6 months on Dilantin, Tegretol, and phenobarb. And finally, some physician says, you know, if he's on Dilantin, Tegretol, and phenobarb, he really needs to be on some sort of tranquilizer because those 3 in combination will cause anxiety. So they put me on Transine, which is like a Valium, okay? And I'm swallowing all of these pills, but from day 4 that I was on Transine, the symptoms went away. I stopped experiencing this. And it was me that went to the physician and said, you know, if the tranquilizer made this all go away, could this have been anxiety? And the physician says, oh, no, it's the combination of medications that's doing it. So we got the right combination now. So keep taking the combination you're taking. And I said, you know, I'd really like to try it without the Tegretol, phenobarb, and Dilantin, and just do the Transine. Oh, no, you can't come off of those pills. I said, why is that? He said, oh, if you come off of that medication, you'll have a seizure. I said, I've never had a seizure. Well, I know, but now that you've been on those medications. Over a period of a year, I did wean myself off the medication, not with the blessings of my physician. Ended up just on the Transine and never returned to the symptoms again. Ultimately looked at it and said, so a tranquilizer did this. Maybe I need to take a look at the 40-plus cups of coffee that I'm drinking every day. Maybe I need to take a look at what I'm doing to my life and how I need to lay off stress that I haven't been laying off. And I made lifestyle changes. Your patients that tell you that they go off coffee and have headaches, you should believe that. That's real. And I weaned myself slowly from coffee to decaf and then even confused myself where I didn't know which can had which. So that, okay, but eventually ended up on a reasonable coffee regimen with lots of decaf added, started working out, started dealing marijuana, which was really helping out. See, you want to relax, you want weight loss. You've got to pick your drugs accordingly, you know. Started drinking a little wine, started doing things to manage stress, and the symptoms have never returned. Now, and I now look back and say that was a panic disorder. That's what was going on then. Okay, I can also tell you, having gone through that, even once they stopped happening, I continued to carry that transine for a good 15 years. And finally realized one day that I haven't taken one of these things for 7, 8 years. And they expired by 10 years at that point. But I kept carrying them, and I wouldn't go any place without them. Because if one of these attacks happened, I knew I could take a transine and it would go away. And it gave me some sense of control over it. You know? So I understand why anxiety patients and panic disorder patients become agoraphobic. I mean, I would still go to the store, I would still go out to school and do that sort of stuff. I wasn't about to go to a Royals game. I wouldn't have gone to a Shockers game. Don't put me in a crowd, because if I weird out, I want to be able to get out of there. And if I'm in a big crowd, won't be able to do that. You know. I was just trying to explain the personalization disorder, wasn't I? Fugue state. Fugue state is when someone disappears, they show up in a new place, always involves flight, and they're amnestic for their previous life. So someone disappears from Minneapolis, and they show up in San Diego with a brand new family, brand new identity, brand new everything, and they have no memory of being in Minneapolis. Sometimes when you check out fugue state people, you find out that the only thing that's memorable about Minneapolis is the fact that they had several felony warrants out for them there. Sometimes, okay? I think fugue happens. I think you should always be somewhat suspicious, you know, because I think it's fairly rare. The next one is dissociative identity disorder. Dissociative identity disorder is old multiple personality disorder brought back under a different name. I applaud DSM for changing the name. It seems like everyone wanted to have multiple personality disorder. And I've not had one patient walk into my office telling me that they thought they had DID. Okay? It's just a less sexy name, and I think it's a good change. I think dissociative identity disorder is very real. I think if you're very fortunate, you may see one case in your career. I think it's very, very rare. Okay? Someone the other day at seminar said, do you ever notice how dissociative identity disorder is like UFOs? And I said, sure, I like a good joke. What's this one? They said, well, there are those of us that have never ever seen one, and those people that have seem to just keep seeing them. So there is that. Okay, and then we have somatic disorders. Malingering. You all know malingering. We've all malingered. To malinger is to consciously fake being sick in order to avoid some responsibility. Okay? You woke up this morning, you really, really did not want to come to this seminar. You could not pull it together. So you called Pam at 6 o'clock this morning and said, I really want to be there, but I'm so sick, I just can't do this. I just can't do this. Is there any way that I can get a refund? Because I really was looking forward to it. I just can't, oh please. And Pam says, okay, there's nothing wrong with you. You're not sick. Malingering. You got a big chemistry test on Monday. You wake up Monday, you don't want to go take the test, so you tell your mom you're sick, she calls into school. Then you go play. You know, malingering. Then we have hypochondriasis. Hypochondriasis is a gnawing fear of having a medical disorder. But it's a single disorder, and it's usually a common type, normally heart disease or cancer. The lay public misnames hypochondriasis. They see everybody that has complaints about bodily function as being hypochondriacs. No, a hypochondriac is very, very concerned that they have one disorder. I just know that I have cancer. So I went to a physician to be checked head to toe. And he came back and said, good news, no cancer. I should have found a better physician. So I go to another physician because clearly the first one missed something. That's hypochondriasis. Somatization disorder is what the lay public calls hypochondriacal. Somatization disorder, I got aches and pains all over my body. I think in DSM for the diagnosis you got to have 14 of them. Various bodily organs, various bodily parts. Oh, my knee hurts. I can tell my liver's not working very well today. I have these headaches and my chest has sort of been palpating all day long. Did I tell you about my ingrown toenail? All over the place. Somatization disorder. So when the public says somebody is a hypochondriac, they ought to be saying that they're a somaticizer. because hypochondriacs stick to one disorder. Okay? Then we have factitious disorder. Factitious disorder people have found out that it's fun to be sick. People step in and take care of you, and you don't have any responsibilities because you're sick. So they go through life seeking to be in the sick role because it's funner than being healthy. When you're healthy, you have responsibilities, and people treat you like crap. But if you'll be sick, people will be nice to you, they'll take care of you, and you don't have to do your homework because you're sick. Okay? They learn that, and they seek to be in the sick role. Now, there's been this disorder is also called Munchausen's disease, Munchausen's disorder. Now, there's been a lot of reports on the news of a disorder called Munchausen's by proxy, where I enjoy being around that sick role, but I don't actually want to do it to myself, so I do it to you instead. You're diabetic, so I overdose you on your insulin. And then your blood sugar level falls to 1, and you start freaking out, and I report that to everybody and then step in to rescue you. So I get to be the rescuer. Okay? Mothers, caregivers sometimes do this to their kids. Put their hands over their mouth until they turn blue, then turn around the room at the emergency room and say, see, he's blue again. What can we do? Seeking to be in the sick role, but I don't care to do it, I'll put you there instead. Munchausen's by proxy. Okay? Labeled by me as really weird duck NOS. Okay? Then we have conversion disorder. I've only seen one case of conversion disorder in my life, or what was reported to be a case of conversion disorder, and that was at VA Wichita. With conversion disorder, you have a psychological symptom that gets converted into a bodily symptom. But there's no basis in reality for the bodily symptom. The most common example of conversion disorder is conversion blindness, where people develop blindness. But when you check out their optic tracts, their optic nerves, there's nothing wrong. There's no reason why they shouldn't be able to see. It normally follows an incredible stressor. You walk upstairs and find your mother having sex with your brother. And for that point on, you can't see. The translation being, you've seen too much. So psychologically, you shut down your visual system. So you're really blind, but there's no physical basis for the blindness. Other examples you'll see, glove anesthesia, where people will lose the feeling, especially common with students. Lose the feeling in all of their fingers, so they can't hold a pencil. Well, there's a problem with that. You could lose feeling in these 2.5 fingers or these 2.5 fingers, but not all of them. There's no nerves that serve all of them like that. And if you had loss of feeling in all of them, you'd also have loss of feeling throughout your arm or your shoulder or something. Just glove anesthesia, so we know it's a conversion disorder. And another conversion disorder you'll see are conversion seizures, and that's the one that I saw. This patient had conversion seizures, kept having grand mal seizures, but nothing wrong with the EEG. No reason for the seizure disorder. Now, I'm not an expert at conversion disorders, but it's also supposed to be the case that conversion disorder people do some strange things. Like people with conversion blindness are really blind, but they'll walk around the chair. They won't trip over it. Okay? People that have conversion seizures don't have them in the middle of parking lots. They have them on mattresses. They have them places that when they fall to have their seizure, they're not going to get hurt. Okay? So it's sort of an interesting paradigm, and I wish I knew more about it. Or maybe in some ways I'm glad I don't know more about it. Yes?
Would a pseudo-pregnancy fall under
Yes. Pseudo-pregnancy falls under conversion disorder, I think. I mean, pseudo-pregnancy to the point that you really start getting large. Yeah. Yeah. All, I think, have a basis of anxiety. So I think any of these that you encounter, what you can suspect is that the underlying problem is a problem with anxiety, and treat the underlying anxiety even though that may not be your primary diagnosis. Okay? Questions about any of these? Yes?
Somatization, that would be usually secondary, what's another diagnosis?
No, somatization could certainly be primary. But I think the thing for you as a clinician to pick up is that the diagnosis here is somatization disorder. Now, you're certainly going to want to have a physician on board here, reassuring everybody, especially you, that there really are no medical problems. They're just perceived by the patient. But your treatment probably ought to focus on workouts at the gym, progressive relaxation, drinking wine, treating that underlying anxiety. With a patient saying, oh, I can't work out at the gym, my joints hurt too much. Well, then we need to do some water aerobics. We need to do some things that your joints won't hurt. With your realization that if you manage the underlying anxiety, some of these other things may become better, may become improved. Yes? I'm not an expert, and if I say anything about it, I'll probably get myself in trouble. She asked me about fibromyalgia, okay? What's the other common one? Chronic fatigue. Chronic fatigue and fibromyalgia. Not an expert in any one of those areas. If a patient came to me with that, I would refer them elsewhere. I think they're probably real disorders, but I just really don't know enough about it. I certainly see them as being in these clusters, If you're watching this as a training video, at this time I'd like for you to refer to the DSM-4TR, and I'd like for you to review pages 421 to 475. And after you've reviewed 421 to 475, rejoin us for a discussion about treatments available with anxiety patients. Thank you very much.